Hello, what's up, team? Happy Thursday. Welcome to VMR. I'm thrilled today because there's two people who I've known for a long, long time. Um, one of which is also happens to be my wife, Kara Lau, who's presenting a case today. This is not Kara's first time. I think it's her third or fourth time presenting a case on VMR, though we chat about medicine all the time. We have not talked about this case, but I did share some sneaky details, very little, with my discussant partner in crime, AMK. And ironically enough, as Karen and I went for a run this morning, and she saw me like doze off and not doze off, but like go into my head a little bit. And she's like, "What are you thinking about?" I'm like, I'm thinking about how I'm going to introduce AMK on on VMR today. And that's because these Thursdays are a great, great tradition where we get to celebrate the people that we love and admire who are part of CP Solvers. And the truth is, my first thought in that moment spontaneously drifted to the first time I heard AMK's voice. And she knows this. Uh, our paths collided a long time ago, about 4.5 years ago, when AMK was in her R3 year of, or two R3 year, I think it was R3 year of residency. And we were discussing a really cool human DX case where the diagnosis, I think, turned out to be thiamine deficiency. But all I remember was, yeah, the case is cool, but like, who is this resident? This is somebody who is really, really standing out, both in terms of the passion that she had for clinical reasoning and also really uniquely how she was articulating her thinking as a third-year resident. It was kind of surreal. And you guys have to imagine this is not like the way it is now, where there's video and like we get to see each other in a much more engaging way. This was like pure audio over a podcast, having never met before. And gosh, I am so glad that that moment has led to so many other more amazing moments. And there's nothing about CP solvers that AMK hasn't touched. She hasn't been part of VMR since its very origins, leading the efforts for over a year, the podcast, and all these projects and tentacles, including actually being the most recent case reviewer for the case review committee. So I feel like it's a little bit silly to introduce AMK to the crowd here, but honestly, it's been really, really cool to bear witness to your journey, AMK. And I think everyone here, especially the junior members, now consider you a mentor and a role model. And we're so grateful for people like you carving out that path. And I am very, very excited to celebrate that today and to continue to really spread that message that all of us here can ultimately reach AMK heights. So thank you for hanging out. Excited to discuss with you, and I'll pass the mic to you, AMK, to say hi, and then to Kara, and then we'll jump right in.
Hello, everyone. I'm so excited, but just to be like real, like kind of nervous to be back discussing. It's been a while, and that case that I did with Rabih was amazing, and it was the first time that I can, missed a diagnosis, not like ever, but on a discussion, but will be the last time. But I've learned so much along the journey, and everything that I've learned has applied to clinical medicine, and I've not missed things in clinical practice because of that. So I come here saying like, I don't know how this discussion is going to go, but it's just the journey and learning along the way. And I'm lucky that I have Rabih to bail me out.
Awesome. Thank you, Vijay, for doing the screen. I don't know if I can bail you out, AMK. We will go through this together simultaneously, I promise. I'll pass the mic to Kara now to say hi, and then we'll jump into the case.
Hi, everybody. I am really excited because I had a theme while I was on night admitting at the county hospital. And so this case very much follows that theme. So I'm just going to jump right into it. This is a 20-year-old gentleman who comes in with debilitating full body pain.
It's a great place to start, AMK. Whole body
Yeah.
pain. What are you thinking? At least I was right
Yeah.
at the age. Told you.
Yeah. So I think this is a really hard chief complaint, because it's really hard when there isn't something necessarily that is immediately obvious to narrow in on. Like if we say right upper quadrant pain, that makes sense. We have a schema. We can attack this. If we say arm pain or leg pain or chest pain. And so it's really hard, like when it feels so broad. And so in these cases, like the first thing I do is I want to come out of a state of believing that the pain is real, because I feel like a lot of people come in and they aren't believed. So like say like this pain is like, no matter what the circumstance, this pain is real, like, but also try to get more information from the patient, like really try to hone in on what is the characteristic of the pain. Like, is it sharp? Is it dull? Is it stabbing? Kind of all those things that we learn in medical school that seem such basics, but can really help us hone in on, is this neuropathic? Like, what bucket are we going to go into? And then try to figure out the time course. Is this new? Did it start suddenly? Because whenever something starts suddenly, that has a very different differential than something that's maybe been going on for a really long time, but perhaps something like tipped it over. So really understanding the time course, is this sudden? And if it is this the first time it's happened, or has it happened multiple times? Because if it had happened, multiple times before, I might be thinking about like, hey, is there some sort of genetic predisposition that's causing something that is somehow triggering this to begin? So understanding more about like where the pain is, what the pain is, has it happened before, and then any other accompanying symptoms. So is there weakness with this? Is there like any sort of like abdominal pain? Is there any sort of headache, neuro symptoms? And then anytime a young person comes in, I really want to understand about who this young person is. So we say like with young people, we definitely think about genetics more. That's something I think about less as a hospitalist, but definitely kind of when you're getting more closer to the pediatric side, I'm thinking about like, could there be some sort of genetic predisposition? You can think about glycogen storage diseases, or, a myriad of different things as the information involves. And then also wanting to know about that person's behavioral. So are they immunocompromised? What certain exposures do they have? Do they have exposures to toxins that could affect this presentation? And then also just thinking about what we say, like bad luck as well. So I'll be excited to hear more information. I think getting clarity will help kind of in such a broad thing, like move forward with it. Rabih, what thoughts do you have?
I agree with you. I think that there's a massive information gap in terms of helping understand the nature of this problem, both in terms of associated symptoms and also in terms of time course, and really what the word debilitating means. But it certainly grabs our attention. But I think if you do an interesting exercise of the knot, and because it is, that's a very vague statement, but it is interesting that the whole body hurts. Is there cardiac tissue everywhere? No. Is there lung tissue everywhere? No. Is there gastrointestinal tissue everywhere? No. Is there muscle everywhere? Is there soft tissue everywhere? Are there vessels everywhere? Are there bones everywhere? So I think if you sit with this for a moment and realize that if somebody's whole body is in fact hurting, there's not many structures that are present in every part of the body. This is not going to be a CNS problem. This is not going to be a cardiac problem. It's not going to be a gastrointestinal problem. And ultimately, what our extremities are our body absent the visceral organs. So I think for me, the range of possibilities are infinite, but the localizations are only one of 4 categories. And these are the only 4 things that are present everywhere. Skin and soft tissue as one category, vascular as another category, osteoarticular, meaning bones, joints, or the periarticular structures, and then neuromuscular, with the neuro here being nerves. And I think that, as AMK said, the time course and the characteristic of the pain will help us understand which of those four structures is involved. You really ask yourself, if this is really whole body pain, those are the only four things that are present everywhere. And so I think careful attention to pieces of history and or exam findings that latch onto one of those categories is going to be really, really helpful. But that's what my mind is going to try to do now, is take all the AMK information that AMK is looking for and try to see if it maps onto one of those four categories. And odds are the exam will be more informative than the history, but key details on history are all the things that AMK mentioned. I'm really excited to hear. What an explosive start. Let us know more.
All right. The setting starts in a familiar place. We're in urgent care. And this is the third time this patient has presented to urgent care. 3 months ago, he came in and noted that maybe he was worried that he had a rash on his arms, but this happened immediately after he was, working and came into contact with, while throwing some stuff out onto his shoulders and arms, spilled onto his front. And so thought it was due to that. They gave him some steroid cream. He went home, didn't most of it resolved, but then felt pretty fatigued. And over the next 3 months, started developing what felt like burning, just pain in his muscles and his bones and his skin. He felt like it was kind of burning him from the inside out. So much so that it actually prevented him from really going back to work. He had to move in with family members and they had to support him because he couldn't really even get out of bed. He was in so much pain. This was also accompanied by what he felt was some nausea, some dizziness when he was trying to climb upstairs, felt like he couldn't even get up to use the restroom. And then what really prompted him to present to urgent care was he felt like he couldn't breathe this morning. And so came in, on presentation, was immediately found to be very tachypnic. And so the rapid response team was called and he was brought over to the emergency department. In the ED, there was some concern when they were talking to him that he felt like he was having some difficulty swallowing, maybe managing his secretions. And they noticed kind of a diffuse redness, from head to toe. And so I will give you the first set of vitals and I'll let you guys take it from there. His temperature was 36.8. His heart rate was 109. His respiratory rate was 28. His blood pressure was 140/85, and he was setting 100% on room air.
Wow, what an interesting aliquot. This information may be waited until later, but I was interested to know if you can share it, what job he does, and if we know anything about the exposures that he might have in his workplace.
Yeah, he collects garbage from and from various commercial places.
Do any of those places have any sort of heavy metals or anything in them?
Good question. I think it's tough to know. I think
Okay.
he described it was he spilled some of this stuff on himself.
Okay. And it wasn't clear what that thing was, or the smell or color or anything of it.
Unfortunately, he wasn't able to describe it. No.
Okay. Thank you so much. Yeah, so this is really interesting. I think the first thought is that there is a more subacute, it seems like, time course. And I'm also starting in my mind, as Rabih mentioned, thinking about the different things that can be on the extremities. I'm starting to map it out to, it seems that there's a neuropathy involved. And the things that make me think about a neuropathy are the kind of burning nature of it. That is kind of something I think about neuropathy. And it seems like there is a sensory component of it. And so I'm definitely thinking there's a sensory neuropathy, but I'm concerned that maybe there could also be a neuropathy involving the muscles, but I think we're going to have to do more kind of digging and exam and evaluation to see. And I'm also concerned with the dyspnea, thinking about like in the difficulty handling secretions, is this something progressive that is now involving the diaphragmatic musculature and the bulbar muscles? So thinking about like something that is now like more progressive in nature and perhaps both sensory and motor. And so that's kind of how I'm initially concerned about this, but I'll definitely want more information, a really good exam, thinking about looking for sensory to make sure to see if there's a sensory level to look for reflexes. And the reason why I'd be looking for reflexes is to think about demyelinating processes. Normally you'll have decreased reflexes, whereas like upper motor, you'll usually be hyperreflexive, at least after kind of the initial phase. And usually in motor predominant things, you will have intact reflexes unless it's like a very severe usually like a necrotizing myopathy. Sometimes you'll lose your motor. So that's kind of one thing I'm thinking about, is trying to map it on and saying, can I have a schema to help me like think through and solve this? And my initial concern is about a neuropathy. I think in this case, like we really have to think about stabilization prior to like being thoughtful, because it sounds like he's tachypnic, has a like fast respiratory rate, difficulty handling secretions. And this is a 20-year-old that I presume has immense physiologic reserve. So I'm thinking about like, are we at the point where we need to consider intubation? Can he protect his airway? Can we get a stat like VBG, a NIF, which is negative inspiratory force, to think about like, is he able to protect his airway enough, or do we need to intubate him first and then think later? So definitely thinking about the stabilization first. And then once we have him stabilized, thinking about the other things, and then thinking about like, this is very concerning in someone who has physiologic reserve. Like this, I'm very, very concerned about him. I think the kind of other things when I get to be more thoughtful is kind of after I've done the stabilization, is thinking about like, if it's a neuropathy, what kind of neuropathy it is. My thought is, because it seems to involve so diffusely, I'm concerned about a polyneuropathy, and at least initially it seems somewhat symmetric, but we'll get more info on exam. But like when I think about the time course, it seems to be more of a like subacute to chronic time course, but it does seem to be rapidly progressing. So I'd still consider kind of the acute causes as well. So just kind of reminding myself with the polyneuropathy to pull up the CP solver schema on that, and think about the acute causes like demyelinating processes like Guillain-Barré, AICP, think about toxins. So to think about heavy metals, which is why I was asking about them, arsenic, thallium. I'd also be concerned about a lead toxicity, but I don't usually, like with some of the GI symptoms. And then it doesn't really seem as much like AIP, acute intermittent porphyria, because it seems like more progressive rather than intermittent, but still something to consider. And then thinking about other like kind of more chronic things, metabolic toxic. This would not be typical of a diabetes. Sometimes like with whippets or kind of other things, they can ingest a nitric oxide that can cause a B12 deficiency, that can cause a myelopathy. Doesn't seem quite right for that. And then kind of thinking about thiamine deficiency, as I had in the past. Again, the time course seems way too progressive. I wouldn't expect some of these like bulbar symptoms and the degree of diaphragmatic weakness with it. But again, something to think about, and it can affect the heart as well, which could cause some of the dyspnea. And then I think I'm really concerned about a possible heavy metal toxicity. And so really, like, I would want to be thinking about that and getting that exposure, but also consider this exposure may have nothing to do with it and be completely incidental. So I'm going to be kind of thinking about the exposure, like in parallel, making sure I get the, like, as much history and think about it, but also say this may be just a random thing. There are meds, but he's not on them. And then thinking about hereditary causes, such as glycogen storage, but again, the time course seems a little acute, and then like inflammatory causes. So thinking about like the sensory level, and then always thinking about HIV and then other kind of infectious causes that may be associated, but again, the time course seems rather, it seems to be rapidly escalating, which would seem a little bit like odd for me, unless there was like some like cervical involvement of an epidural abscess or something like that, but that just doesn't seem quite right. So I'll be excited to get more info. Sorry I talked so long, but I think now we have some threads to follow and really need to stabilize and then, you know, really be thoughtful about what's going on, because this is a really serious process. So Rabih, what other thoughts do you have?
Yeah, I don't think I have anything else to add, AMK. I think like you, I'm following two different threads. I'm following the body thread and then more alarmed by the respiratory thread. I think if we establish a general principle about dyspnea, which he has, and dyspnea comes down to one of two issues, either an issue with gas exchange, or if somebody has shortness of breath without a gas exchange issue, then there must be a problem with their dyspnea sensors. So here, if we say, okay, is this a gas exchange issue? We know it's not exchanging oxygen. That's the problem. The open question is this a carbon dioxide exchange issue, i.e. a ventilatory issue, or is this actually an issue with dyspnea without gas exchange problems, such as a panic attack, such as dyspnea from anemia, or such as dyspnea from arrhythmia? And I think when somebody has tachypnea, it's really, really hard to know. Are they having tachypnea because they have a problem with ventilation? Or are they having tachypnea because their dyspnea sensors are off, but there's no pathological issue with gas exchange? And I think that's the tension that I'm trying to figure out. The fact that he has secretions in his mouth is very, very intriguing, because it may represent one of two issues. It may represent excessive generation of excretions, which may be fitting with a toxidrome, which you already alluded to with his rash, or it may be because he has issue clearing those secretions, which represent an obstructive or neuromuscular issue. So I think there's the respiratory dimension has two open-ended questions. The first is he making too many secretions, or is he not clearing them? And the second is he having ventilatory failure or a dyspnea sensor issue? And those things are going to be very, very important to tease out. With regard to the whole body stuff, I think this case is so illustrative of how hard it is to diagnose neuropathy on unhealthy skin. Most of the time when people say they hurt and we diagnose them with neuropathy, we look at them and we don't see anything with our eyes. And we say, oh, you're hurting, and I don't see any reason for you to hurt with my eyes, so you must therefore have a nerve problem. And I think it's going to be really, really tough to say, does this person have a neuropathy, or are they hurting as an appropriate response to the erythroderma that they seem to have? So that's going to be a tough one. And I think that's where, as expected, the exam is going to be much more powerful than the history when a patient presents with whole body pain. And the exam open questions are going to be, are there signs of neurological compromise apart from discomfort? Because the discomfort might be cutaneous in origin rather than neuropathic in origin. And is this patient having excessive secretions in his mouth, or is he just having issues clearing them, which again is more a neuro versus non-neuro categorization? So a lot of things to try to tease out first. And I think that's those threads that I'm following. What's the skin? What's the secretions? And what's the ventilatory status here to be able to make more progress? But I agree with you. A very, very critical situation that has to be handled with care and nuance to get it right. All right, Kara, tell us more, please.
Thank you so much for the fabulous discussion. So just to make it explicit, he doesn't have any past medical history. He's not taking any medications, doesn't use any substances, and doesn't know too much about family history. and doesn't have any known allergies. So on exam in the ED, he is pretty like uncomfortable appearing, grimacing in pain, and has a pretty significant rash, which I will show you in a little bit. HENT, he has eye redness and pain with extraocular movements, but no icterus. He has round reactive pupils. Neck exam, no lymphadenopathy. Cardiovascularly, normal rate and rhythm, no murmurs. Pulmonary wise, he's tachypnic, but is actually protecting his airway quite well, and has clear lungs. Sorry, just to add to the HENT, it's not like he has copious secretions, but he's like swallowing a lot, like seems like he's having trouble with that. But is managing his secretions. Abdominal exam is benign. And then neuro exam, he has intact extraocular movements despite the pain with them. It seems like intermittently maybe disconjugate gaze, but doesn't really have a consistent pattern and does endorse some diplopia when he's moving his eyes. He has no fatigable up gaze. His facial strength and sensation is intact. He has no dysarthria. Motor exam wise, maybe he's quite thin, maybe mildly reduced bulk, but has normal tone. He doesn't have pronator drift. And then his neck flexion. So I'm gonna just list like what's weak. His neck flexion is like 4 out of 5. He has 4 out of 5 deltoid strength. He has 4 out of 5 iliopsoas strength, and everything else is pretty much intact. Nothing is fatigable. And then he has normal reflexes, grossly normal sensation, intact finger, nose, finger. And he did walk, and it was narrow based, and it looked like it was mostly limited by pain, but didn't seem grossly abnormal otherwise. And let me show you guys the rash. So the emergency, like, how would I describe it? It looks like there are areas of like stronger or more hyperpigmented areas, but he's pretty like erythematous all over, so it wasn't an inaccurate description. I know the lighting makes it seem like it wasn't necessarily the case. And then it's really concentrated mainly over actually his entire face, his ears, across his neck, around onto his chest, on his belly, down both his shoulders, and wraps all the way around both of his arms, over his knuckles, and then less on his thighs, more on his knees, and over the dorsum of his feet.
Is that in for the aliquot?
Yes.
Okay. Awesome. Well, I think this is really helpful information. And I think it helps us kind of localize it, like what's going on a little bit more. It seems like, kind of just to summarize, that there is proximal muscle weakness, but less so distal. Is that correct, Kara? So proximal muscle weakness with a rash that appears more localized in some places, but can have some localized erythroderma. Seems to be some involvement of the eyes as well, but seems to be like sensations appears to be grossly intact on exam and has reflexes. So when I'm thinking about this is kind of shifting my differential, which is why having the exam is so helpful, because now I'm going away from something like a Guillain-Barré, an AIDP, a CIDP, because of the reflexes which are present on exam. That's not 100%, but I'm thinking more about like the involvement of the muscles and saying like, it seems like there's proximal muscle strength. And so I'm wondering if there could be involvement of a myopathy as well. So I think that like is just how thinking about the exam is helpful. It is very relieving. It's protecting the airway. It doesn't seem like we need to pursue like urgent intubation. Like we have time to figure out what's going on with his dyspnea and be thoughtful about that. Kind of putting everything together, I think is still thinking about like the rash. So it seems to be that there is a skin problem. I'm concerned about a muscle problem. And then it seems like there may be an kind of conjunctival ocular problem as well. So I'm thinking about like, are these unrelated? Are they related? And if they're related, are they part of just one process or kind of multiple processes together? So thinking about that and thinking about like redness with localized rashes. I'm thinking about like, is this erythroderma? It seems less likely to be erythroderma, but definitely something we need to consider because this is life-threatening. Psoriasis can cause erythroderma, as well as kind of various other etiologies, including things like Norwegian scabies, which doesn't seem as likely as there isn't a significant amount of itching, but really thinking about is this, and then thinking about where it localizes. It seems like it localizes on the knuckles, on the back of the neck, thinking about like, is this a sign of some sort of autoimmune disease such as a myopathy? And so thinking about like, is there some sort of dermatomyositis present? I'd be curious if there was any photosensitive component of the rash as well. And then I think the lack of fatigable up days makes me think less likely something like myasthenia gravis or something that would become fatigable with time. So now, like based on this, I'm really going to be curious about thinking about like the labs. Is there pancytopenia? Thinking about like, is there signs of muscle breakdown on the labs? So thinking about a CK level, and then thinking about an aldolase, and then is there any other signature of autoimmune disease? I'd be very curious with the tachypnea. He's saturating very well in room air, but also has a lot of physiologic reserve. I'd want to be thinking about a VBG, but also be thinking about if we're concerned about like possibly a autoimmune disease, thinking about is there subtle involvement of the lungs? So thinking about, do we need to pursue further imaging, thinking about chest x-ray, but a lot of times the chest x-ray won't catch subtle involvement in ILD. So if we do become concerned about it, thinking about getting that high-res CT, especially to try to catch it early, is it involved, but also thinking about like, could this be a diaphragmatic problem as well? So thinking about like, is it a strength problem? Is it a subtle parenchymal problem that is just not visible on stethoscope or, like imaging yet? Or is this like anemia or kind of some other process causing it? So I'll be excited to get more information. Rabih, what do you get from this aliquot?
Oh, AMK, I have nothing to add to your analysis. It just goes to show that like if you're taking care of this patient in real life, with all due respect to the history, the power of the exam in a patient who's saying that they hurt is way, way more. And if you just track how much more progress AMK was able to articulate in the exam compared to the history. So what happens in real life with these patients, if you're invested in being as efficient in your diagnostic skills as possible, you're getting the history while you're doing the exam. And because the exam is giving you so much more powerful information that you're tailoring your history and your questions in the history now in a much more specific way.
Yeah.
In terms of the management reasoning that I think would be happening right now, I think the correlation of neck flexion weakness to diaphragmatic weakness looms large. And I think that this is a patient for whom you want to optimize their diaphragmatic breathing. And the way to do that is to move everything out of the way for the diaphragm. So if this patient's lying flat on their belly, the abdomen has to push away the liver and the spleen. But if you have the patient sit up, and everything drops down away from the diaphragm, this patient will probably breathe comfortable if his diaphragm is involved, which AMK suspected a long time ago. And that suspicion is only higher now given the both proximal weakness, but more importantly, the neck flexion weakness. And so what you can do about that in many instances is either have respiratory therapy do what's called the mean inspiratory force to help you understand if there's respiratory muscle weakness, or you can do a simple physical exam maneuver at the bedside by asking the patient to see how many numbers he can count to in a single breath. So 1, 2, 3, and so on. I forget the cutoff, but I think it's about 20 or 30. You should be able to count off with a single breath, and anything less than that. We should look that up. But basically, I think now you can easily make this patient much sicker if you prioritize pain control with potentially opiate medications, forgetting that his ventilation might be compromised. So those are the small things I would emphasize in terms of managing this patient. Is careful with sedating medications. His breathing is probably impaired. Make sure that he is sitting up so that his diaphragm has as much room to work with. And your insight into the strength of the diaphragm can be confirmed with respiratory therapy doing a mean inspiratory force, but can be inferred by the breath test, which the numbers we'll have to look up specifically, but its value is pretty high in this patient. Really acute presentation of what looks like something is smoldering, but it looks like the disease is going to declare itself when it's this bold and brazen. So let's see what we have
Okay. AMK, I'm going to give you basically all full of what you requested. So initial VBG 7.5329. CBC, white cells 9.1, hemoglobin 16.2, platelets 245. BMP, sodium 138, potassium 3.4, chloride 104, bicarb 20, creatinine 0.6. AST is 86, ALT is 55. CK is 408. CRP is 3.5. ESR is 9, normal troponin, normal lactate. Rheumatology and dermatology are consulted and come down to the emergency department. Dermatology gets a biopsy and disappears. I'll stop there.
Awesome. Well, this is really helpful information. Was the WBC count normal?
Yes, 9.1.
Okay. Oh, sorry. I think I totally missed it. So just like looking through the labs, and I'm just going to do it systemically just because so I don't miss anything. I noticed is that hemoglobin of 16.2. That might be nothing, but it does make me question if there has been a little bit of like subtle hypoxemia that's been lingering in the background, but it could also be just the dehydration kind of lab. So I'll be interested to see how that plays out throughout hospitalization. It is also, it sounds like what was a previous healthy 20-year-old, which I'm not used to seeing in the hospital. And then thinking about the other labs, so the AST and ALT are both elevated. It makes me wonder about a muscle cause. Generally, kind of the rule of thumb with AST and ALT is that AST to ALT is in a 4-to-1 pattern in the muscle. But over time, since AST has a short half-life, they'll kind of come together and like normalize and be about equal and like more subacute process. And so I'm wondering about that, but I don't feel like I have enough information to say, you know, the CK is elevated. It's not sky high to say this is all CK. And so that's just something I'm going to be thinking about is, you know, it's probably due to the elevated muscle breakdown, but also be thinking about there could be some other sort of liver process at play. So don't completely neglect that. But the fact that the AST is elevated above the AAT definitely makes me concerned about that. The CK is elevated. It's not sky high, but I will say a lot of times in myopathies, because they have a slower time course, in like the more inflammatory myopathies, they aren't super elevated. You'll see them like in the few hundreds to low thousands. And sometimes even the CK will be normal and like you'll need to check an albilase. Now in necrotizing myopathies, they're usually quite a bit higher. So I think that this could go with our hypothesis, but I definitely don't want to center, but it certainly tells us there is muscle involvement, and there is inflammation. And so, I'm thinking about, is this inflammatory myopathy, but also want to be thinking about the other causes, infectious, other autoimmune diseases. Could it be some sort of mixed connective tissue disorder? I don't see a lot of data for that, but definitely something that could be at play. In regards to the VBG, I've been avoiding it just because it's hard to think through VBGs on the fly. So this is alkalosis. And I was a little bit surprised that the CO2 was pretty much in the normal range. Frankly, a little bit surprising to me. And I'm like trying to think on the fly because I was like, since the CO2, now this is a VBG, there's some correlation. It seems like maybe the hyperventilation could be affecting it some, but since the CO2 isn't really low, I'm thinking about like, is there some sort of metabolic alkalosis at play? I think maybe the chloride is a little bit high. So, but the good news is that, the not like super low now. And so maybe some hyperventilation, maybe some metabolic alkalosis, but that makes me feel a little bit better that at least as far as gas exchange isn't getting acidotic now. Rabih, what do you have to add?
Not as per usual, my friend. I think I really appreciate the way you taught the nuance of the CK. I think it's very, very tempting if you're beginning to understand these diseases to like say the CK is not high enough, but you're right. The subacute indolent nature of the inflammatory myopathies renders many of them strong contenders for a CK this high in the presence of weakness. And I think just to explain the terms around these circumstances, the term myopathy means the muscles are weak. How do we know the muscles are weak? We do an EMG. How do we know to do an EMG? Most of the time, patients with proximal weakness will have an EMG that correlates with muscle disease. So here's the leap that we're making. We're saying proximal suggests muscle disease, but there are many other conditions that can also do proximal muscle weakness. So presumably this person's muscles are weak, and so that's a myopathy. Done. There's a gradient of the CK positivity in myopathies going from usually normal in inclusion body myositis to through the roof in autoimmune necrotizing myositis. So here the elevated CK certainly reinforces the notion that the proximal muscle weakness is the result of a myopathy. And so AMK, I think that right now we're probably going to have to say we're really suspicious about a muscle issue. We already talked through that. And the question really that looms large is the skin issue a clue? And so we call this a skin and muscle disease, or are they true and unrelated as a result of the potential exposure that this person had? And so I think yeah, I think that that's what I'd be doing diagnostically. From the ABG or VBG perspective, you said it exactly right. I think that this person has a primary respiratory alkalosis, and their two Ps are the most common drivers is pulmonary compensation. So does this person in fact have diaphragmatic involvement? And because the diaphragm is weak, is hyperventilating to compensate for that weakness? Or the other P, pain, and managing that tension of the pain that he's obviously in versus the pulmonary disease that he likely has is a really tricky one to navigate. I think it'd be tricky to think about in real time, AMK. I'm curious to get your thoughts, what you might be doing in as next steps. What do you think would help you make progress?
Yeah, so I And I'm sorry, when I misheard 39 on the CPG, not 29, which so it's very clearly respiratory alkalosis, but that's why I was like, before. So I think in real time, like I think getting the right people, making sure the patient's stabilized, and then getting the right people involved. So I think it makes a lot of sense to get dermatology. It's an easy site to biopsy to, again, like with our hypothesis, are these the skin and the lungs, or the skin and the weakness related or unrelated? And then I think it makes a lot of sense with rheumatology too, kind of as we're working through this. I would be thinking about kind of sending my kind of general weakness panel, including a myositis panel, but I also be like thinking broadly and thinking about like, you know, HIV, asking like vitamins, everything like that, as well, kind of in the meantime, just to make sure, again, not like missing anything and make sure that I'm really getting that good exposure history as well.
I'm right there with you. I think that that exposure history is going to be really, really key. And for me, whenever we're starting to build suspicion for an inflammatory myopathy, I remind myself that that term is actually insufficient. And in fact, most inflammatory myopathies that are systemic fall into affect one of four organs: the muscles, of course, the skin, as you alluded to, and then the two other ones, lungs, and then vessels. And so I think looking back at this patient's history in terms of the vessels category, to be like, do you have Raynaud's? Are the fingernails periungual area, is that dilated, or is there capillary dropout? And then for the lung disease, I think because of how much we're talking about the lungs, the trip to the CT scan that you alluded to, well, you actually explicitly mentioned a while ago. I wonder if we might make that happen from the ER, because it gets harder and harder to get it done for a sicker patient. But yeah, cautiously proceeding. But I'd say my piece of advice is, whenever you're thinking about inflammatory myopathy, remember that there are four organs that are very commonly involved: skin, muscle, we talk about that a lot, and then the lungs and the vasculature are often overlooked and can give you a lot of momentum to the case. He has another interesting manifestation, which Carol is hinting at, is maybe he has oropharyngeal dysphagia. So if we lock that in and say he has proximal muscle weakness and dysphagia, then the overlap of conditions becomes even narrower. So a barium swallow might help you do that too. Really, really interesting case. What happened next, Carol?
Yeah, so huge kudos to the emergency department, who called room actually before we saw the patient. But initial preliminary swallow with bedside and then with speech were abnormal, but not like it didn't. He definitely had dysphagia. No history of Raynaud's, no like like nail changes. Room came and evaluated him, and had neuro come evaluate him also to confirm the initial exam. And they were concerned enough about the combination between the dysphagia, which they considered a very poor prognostic marker, or not prognostic marker, but concern for very severe disease, plus the proximal weakness and this rash, which they very much described as like Gottron's papules and like a Shaw sign, that they needed to just treat empirically for dermatomyositis, and then send a lot of the work up that I'm seeing in the chat. So he got pulsed. And then I'll give you guys kind of some of the preliminary room workup and the imaging. His initial rheumatologic labs, well, first, initially his infectious labs, negative hepatitis serologies, negative quant gold. He had an ANA positive titer of 1 to 80. He had a C3 of 81, which is slightly low, a C4 of 31. dsDNA that was positive at 31, RNP negative, Smith negative, SSB and SSB negative, SSA mildly elevated, aldolase of 12. He got pan scanned, completely unremarkable. And I can give you the initial, we can just skip ahead a little bit to the skin biopsy results, because we actually got that before a lot of the rest of the rheumatologic workup. The impression is interface dermatitis consistent with connective tissue disease. Comment, these features are consistent with connective tissue disease. While lupus is a consideration, the absence of deep perivascular and or periadnexal inflammation, the presence of vascular ectasia are most consistent with either dermatomyositis or a mixed connective tissue disorder. But there's a much lower concern for a phototoxic drug eruption, given there's no keratinocyte injury at the level of the epidermis. And other concerns that the pathologist had were an interface drug reaction or a viral exanthem, but recommended clinical correlation. And the next aliquot will have the myositis panel for you guys.
Okay, awesome. Well, I think this information is really helpful. The ANA being positive, it can be positive in a lot of different autoimmune diseases. I think the thing we always jump to is lupus, and it can also be in up to like 20% of females is positive without autoimmune disease. So I think it's helpful that it's positive, but it does not say like this is, you know, one autoimmune disease. The double-stranded DNA is interesting to me. It seems like very, very mildly positive, which is much more sensitive for lupus. So I would be like wanting to make sure there wasn't like kidney involvement, other things. But I think in and of itself, I would still rely on kind of all the clinical data rather than just like one mildly elevated autoimmune disease. As autoimmune diseases can also kind of like be associated with sometimes just other positive antibodies as well. And I'd say that as well with the positive SSA. So I do feel like we have to consider mixed connective tissue disorder, but at least like for myself, I don't feel like, unless I'm given another data point, I still feel very strongly that this is dermatomyositis slash like maybe an antisynthetase syndrome. We'll see. It doesn't seem like the pan scan had the lung involvement. So I still would think that and be waiting for the dermatitis panel, but treat this like dermatomyositis. Rabih, what do you have to say?
You're such a pro. You know what I really appreciate and being in the discussion seat every week, multiple times a week, is to see somebody who's really, really skilled, and like I think I suspect, reading between the lines, that you were thinking about dermatomyositis a long time ago, but you're showing us and modeling for us just how you solve these problems in real life, where you don't want to just jump to the answer, that you keep it as a potential destination, but you're very thoughtful about what else you could go. And I completely agree with your analysis here. We should think about lupus, but then we're like, there's no kidney injury, there's no cytopenias. We shouldn't think about overlap connective tissue diseases because the person could evolve to have lupus in the future. Thankfully, I think that the RNP being negative makes it a little bit less likely to have to contend with mixed connective tissue disease. And if you're listening to this and you're confused, it's very, very confusing. When people have multiple connective tissue diseases, we call that having an overlap syndrome. When people have a specific kind of autoimmune disease characterized by a high titer positive anti-RNP, that is termed mixed connective tissue disease, and it has a very, very specific fingerprint that tends to pick and choose between things that look a lot like other connective tissue diseases, but is a specific syndrome with reportedly better prognosis, but people think that that may be questionable. And I'm right there with you. I think that this is a very, very concerning case for dermatomyositis. And the open questions might be, in terms of understanding dermatomyositis, is one intriguing aspect is this patient's young age. And I think more and more so, the world of dermatomyositis is being split into many different kinds of worlds, which you already alluded to with the term antisynthetase syndrome. So about 15 years ago, all these conditions were lumped into the word dermatomyositis. But with more and more understanding of the disease, we now try to file them by their antibody status. And antisynthetase syndrome is a specific kind of syndrome characterized by antibodies to the tRNA synthetase usually the anti-Jo antibody, but many other ones. And VJ, our scribe today, presented a case of this causing an ILD a long time ago. What is interesting here is the possible overlap with within dermatomyositis of an antibody type called NXP2. I don't know this world too well, but it is a condition that affects usually younger men with dermatomyositis. And the other curious fact about it is it has a prominent dysphagia component and usually has an underwhelming CK component. And the underwhelming CK component is felt to be because the muscle involvement is both as a result of the inflammation of the muscle, but actually a prominent vascular ischemic component. So I think the myositis antibody panel is going to be really, really helpful. And more so, diseases of dermatomyositis are being defined by the antibody panel, both in terms of what the behavior of the disease will look like, what kinds of dermatomyositis-y things it does, but also more importantly, the rate of ILD and the rate of cancer, the two more morbid underlying possibilities. So I both agree with the myositis panel for diagnosis, but also close attention to which antibody type it is that'll influence a lot. Alrighty, Kira. If the myositis antibody panel is negative, AMK, we should reassess, but we've invested heavily in that.
So the antibody panel comes back. Most prominently, Jo-1 is negative, and so is the MDA 5-3. I can't, it's all jumbled in my head right now. Actually the U3-RNP is also negative, making again the mixed connective tissue disorder disease less likely. Of the antibodies that are positive, TIF1 is high positive, and P155 140 is also positive. And I was doing a little bit of preliminary digging, though I have much more to read. And the TIF1 high positive actually correlates very well with his skin predominant, rapidly progressive, like painful condition. He gets pulsed. He pretty significantly improves. There was some concern that with like the issues with eye movements and like the bulbar, the concern for bulbar weakness, that he needed more aggressive treatments. I think he got IVIG also, but overall improved significantly enough to be able to start a prednisone taper and get discharged from the hospital. He got full body spine, the whole bit, MRIs, got a testicular ultrasound, and all of that workup thus far has been negative. And so right now we have yet to discover an underlying neoplastic syndrome that could be driving this. And so I think ultimately the thought was this is like quintessential dermatomyositis.
Oh my gosh, so cool. AMK, what are your thoughts?
Yeah, so I think my thoughts on this case were, it makes me sad that, I think it's really hard because sometimes things are very unclear as they're unfolding, and there was this like exposure and, like a lot of things going on, but how hard it is sometimes for patients to like get the help and diagnosis that they need. So like just really trying to like do everything that we can, recognizing that sometimes things aren't clear and, kind of unfold in a way. But also, I think as I was going through this case, I think sometimes it's really easy to like hear the history and like perhaps jump to incorrect conclusions, or when there's so much going on to make like assumptions, or put too much in a history, or like forget about the erythroderma and the first aliquot. So just like, I think in real life, just like really being thoughtful and like gathering your thoughts and like doing a good exam as you're going on to like not fall into a cognitive bias would be some of my thoughts. And I am also thankful there are very smart people like you who know all the different like antibodies and all this stuff, because that's a little above my head.
Yeah, I know, AMK, I think that yeah, you think about this person's journey, he's 20, and gosh, I think being diagnosed with this condition is not a small deal for him, and it'll have tremendous impact probably for the rest of his life, especially it takes one Google search to realize that the rate of underlying cancer in many forms of dermatomyositis, especially in TIF, is not low. And so I feel for him, but it's also in parallel, just realizing that this is an emergency room that actually called rheumatology before they called medicine, and the availability of these resources for this patient is also pretty cool and pretty rare and wonderful to hear that he got. Yeah, I really, I think there are a lot of lessons in this case. And to go back and think about the chief concern of whole body pain ending up with dermatomyositis is very, very humbling and quite the journey. It illustrated for me, I think, just the power of waiting to see what the problem is before you solve it. And when you see that rash and the rash over the knuckles and the proximal muscle weakness is a much easier problem to solve than whole body pain. And that observation is only a minute or two later. Whole body pain, rash, proximal muscle weakness. And that minute really, really can help you be able to execute your cognitive energy in an efficient way. Kara, what was it like for you?
Oh, I mean, it was just really cool to see like the specialists already at work when I was down there. And this, I mean, I think there was a lot of, I mean, because this was like so rapid onset in a person who was so like young and had no other risk factors, there was this huge concern for malignancy. And so also like having those initial discussions with this poor person who was like, I thought I had a rash, but then also seeing the trajectory of improvement afterwards really just harkened back to like really having like being able to, like you said, not anchor on the initial diagnosis, but like recognize the constellation of data that allows you to make the diagnosis efficiently. Yeah.
Absolutely humbling, and yeah, a lot to reflect on in this journey and a lot to hone in on. But before we pass the mic to Anmol for her outstanding teaching points, I'd love to pass the mic to Maddie, because her voice will be familiar to you later today.
Yeah, hey everyone, really an amazing case presentation, Kara, and discussion, AMK and Rabih. I just wanted to announce to everyone listening that if you want another VMR today, we will have another session, an intern bootcamp session at 5 p.m. PST, 8 p.m. EST. And it's open to everyone, but it's really targeted, the warning is targeted to rising interns and residents. And the whole point of these sessions is just to cover some common internal medicine topics to help incoming residents feel comfortable with common topics. So today we'll be discussing hypotension. So really encourage you all to join if you want some more learning. All right, Anmol, teaching points, the mic is yours.
So amazing case, everyone. I'm sorry if other voice is coming up. Please let me know. I'll try. I think teaching points are at a function. And okay, so it was an amazing case. The first complaint we had was of full body pain. And we thought, when we think of full body pain, we are always confused if it's a generalized or like a localized pain. When we have a localized defined pain, we're better able to make our differentials. So then we also thought if it could be subjective, if the patient was actually feeling the pain, or it was actually there was something, or there was not there anything. And then we think about the characteristic, if it's sharp or stabbing or burning pain, which makes us narrow down our differentials. And then we can also think about the onset of the pain and the duration of duration, and if there has been any previous episode for that. And then we think about if any associated symptoms, if they were present. And then he was a young patient, so we think about genetics, risky behavior, or bad luck. And then we also think about involvement of neuromuscular, skin, osteoarticular, vascular problem rather than a specific system. Then if I say the patient also had dyspnea and dysphagia, so we thought about the probable involvement of diaphragm or bulbar muscles. And then we saw that the patient had burning pain, so we thought about maybe some sensory neuropathy, which actually Dr. Anne-Marie thought to be polyneuropathy. So we maybe thought about to check the reflexes and to inspect the skin to look for any rash, because whenever the patient has any burning pain, we have to inspect the skin if there is something, a clue we can find there. And this seemed to be acute, this neuropathy seemed to be acute and progressive. So we thought about some demyelinating processes like GBS, toxins, heavy metals like arsenic and thallium. And since the patient was tachypneic, clinic. So we thought that it's important to stabilize before diagnosing, and it's important to protect the airways and do the VBG. And we thought about if there's an issue with gas exchange or there's problem with gas exchange centers. So is it like CO2 exchange issues, or what, like, which could make us think of panic attack or anemia. And then the patient had secretions in mouth, which could be due to two causes. If it is excessive generation of secretions or problem clearing the secretions. And then we had a proximal muscle weakness plus rash, which pointed towards a myopathy. It could be conjunctival ocular problem. We just thought that myopathy or conjunctival ocular problem was it isolated or were they connected? And the rash could be erythroderma or scabies. And most prominent on knuckles and neck, we thought it could be more of an autoimmune myopathy like dermatomyositis. And non-fatigable weakness makes us drift away from myasthenia gravis. Then the patient had diaphragmatic weakness. So we actually thought that whenever the patient presents with diaphragmatic weakness, we have to do for respiratory therapy, the mean inspiratory force, and we have to just do some tests like how many numbers can the patient count in single breath so that we can measure the diaphragmatic weakness. And then the patient had elevated liver enzymes and CK, which made us more concerned about inflammatory myopathies or mixed connective tissue disease, and underwhelming CK levels also made us more towards inflammatory and less towards necrotizing myopathies. And the inflammatory myopathies, which are systemic, which we mainly concern of that they involve skin and muscles, but they can also involve lung and vessels, just like we saw in one of the previous cases where interstitial lung disease was a manifestation of inflammatory myopathy. So whenever we have a myopathy, how do we define it? It's basically weak muscles. For that, we do EMG. And whenever we have a proximal muscle weakness, we actually say for sure that this is a muscle disease. And for that, we need myositis panel, HIV, vitamin levels, exposure history to just confirm our diagnosis and rule out certain things. And then from VBG, we saw that the patient had primary respiratory alkalosis. So it could be due to two P's. One is pulmonary compensation because of we think that the patient is having some diaphragmatic weakness. And the second cause we think of is pain. And then the patient had mildly positive double-stranded DNA, which made us think of lupus. But in lupus, we also think of some renal manifestations or manifestations in the labs as cytopenias, and they were not there. So that then we also thought about some antibodies like NXP2, which is anti-nuclear matrix protein 2, which is present in young patients, and dysphagia is the main component. And we have underwhelming CK levels in that. So we thought about that. And TIF1 antibody makes us think of more towards a cancer or a paraneoplastic etiology for the presentation. And I love the case, and I'm sorry for any disturbance. I tried my best to do the teaching points. Thank you so much.
Oh my gosh, Anmol, I don't think this has ever been done before. Where what kind of function are you at?
I'm at my friend's wedding.
Oh my gosh, Anmol. Oh my, your dedication to VMR will never ever be matched. That was unreal and really, really cool. Thank you so much for both capturing all these teaching points and delivering them with quality that is unmatched, and somehow having your voice overpower that of a wedding function. That was unreal. All right. Well, thanks everyone. Thanks AMK. Thanks Kara. Thank you VJ for scribing, and of course Anmol for outstanding teaching points. We'll look forward to seeing some of you all tomorrow morning. Bye.